Start with roll call. Jody, here. Deidre Blankenship.
Here.
Jay Cloud. John Creech.
Here.
Robert Gonzalez. Greg LeMay. Lori Lefevers.
Here.
Wade Olson.
Here.
Taylor Ratcliffe.
Here.
Oscar Salazar.
Here.
Kelly Weller. We do have a quorum. Thank you all for being here this morning. It's been a very eventful month. We've had a lot of things going on. I'd like to thank members of a couple of committees that have been working with us, from the medical director committees. We still continue to look at advanced practice and EMS committee with some input from all. And I'd like to also thank the Coastal Bend RAC office for hosting us on our April 10th meeting. Item 1 is development of the advanced practice paramedic community health curriculum. The North Central Texas Trauma Regional Advisory Council. Anybody here from the RAC today? I don't have my glasses on. Nobody? Net RAC? Anybody here?
From the RAC, but I'm not the RAC.
Okay, well, you're going to represent them till somebody else gets here.
Congratulations.
Some of you in the audience, officials from the state, had an opportunity to come to the Community Integrated Mobile Healthcare Symposium, Improving Patient Outcomes and Reducing Cost seminar that was held by the RAC. When we looked at the flyers and we talked about these at our last 2 meetings, we knew it would be informative. We knew it would be persuasive. We knew that there would be a lot of information there. But I can't tell you how really good it was unless you were there. Joe, you were there. They put together a ton of speakers with background and knowledge to bring us, I think, some pretty good parameters to work with. Joe, you feel the same?
I would agree 100%, with a lot of rain, too.
Yes. Yeah, a ton of rain. That was the day we had our first little tornadoes start coming through with this change in the weather. I talked to Melissa Christian, who has been diligent in her efforts to bring this information forward. There were several PowerPoint slides, and with her permission, I'm going to give you about 3 to 4 slides from each one. There's no time to go through all of them. Just kind of want to give you a synopsis because they were able to put together a lot of content experts. We got to look at a lot of departments. And Dr. Sharon Malone is here today, and when I get to her slides at the end, I'm going to have her come up and have her explain her own slides because she was one of the wonderful presenters. You know, guys, we're hearing information all over. We're watching, and as a result of the Education Summit, which we'll talk about later, and the Integrated Mobile Health Seminar, we found out there are a lot of people doing some form of whatever we want to call it. And again, we're still kind of hung up on the names, even though this committee has adopted advanced practice when we're just talking about it. But whether it's community health or mobile integrated health, we've got a lot of people doing a lot of good things out there. So I want to see if we can just take some of those things from them. I'm going to run through these. There's 250 slides, so get a cup of coffee, sit back. No, they're really 257 slides. We're just going to hit a couple of the highlights from what the RAC had put together for us, and I think it'll be very helpful when we're looking at a workshop. Hospital EMS and relationship in the era of accountable care. Ms. Jenkins, who's president of Dallas-Fort Worth Hospital Council, had a very informative, when we were looking at numbers, we were looking at what is this going to cost, what are we going to be able to do, and what are we trying to do with it. And I can tell you the Hospital Council is all for it. They're looking, saying, what can you all do, how can we help you to help reduce cost? And I think as we all study and we begin to look, we know that sometimes it's not a direct cost to us, but some indirect savings that will allow us to move. She looked at healthcare systems, a new challenge, a new paradigm shift, opportunities to partner. Hospital Council really wants to partner with anyone who has any ideas, any knowledge, any performance criteria, so that they can help them and work with them as we move toward more integrated health and the benefits of coordinating through them. Most of the presentation from Ms. Jenkins was the new paradigm, and that was looking at the factors that you see there on the right-hand side, which are the big challenges. She actually took us through several challenges, but most of them looking at the risk of reimbursement with things with Patient Affordable Care Act, how we coordinate care, how we involve EMS, how we involve nursing, how we involve physicians, how we our referred patients, the community benefit, which was spelled out for us, and the partnerships. And she probably stressed more of the partnerships than anything else. Was to make this effective, you've got to have partnerships, and partnerships with EMS for people that we probably haven't thought of in the past as partners. People that were durable medical equipment, a lot of social work, because I don't know any paramedic program that teaches social work. And when we're out trying to take care of Ms. Smith, and Ms. Smith needs a new walker, a crutch, or referral, whatever, that's not stuff that we've done. We always will take it to the hospital and let them handle it. So a lot of that information shift and a lot of that partnering is going to have to be with some of our providers to give us some information that we need. Chris Wanzapple, who was director of EMS for Rowlett Fire Rescue, was looking at the customer service level, and he pretty much stayed with the fire service on this one. And it was a very interesting topic. At the IAFC 2013 meeting, it said over the course of the past several years, the fire service has been subject to increasing scrutiny. Economic pressures, evolving communication technologies, changing social norms contribute to an environment wherein the fire and emergency services find ourselves struggling to maintain a positive image. And if you've been watching TV lately, I would say, especially up in the North Texas area, we've had a couple of incidents that just haven't shown us in a positive light. We have a lot of people asking a lot of questions. The internet is a great tool, and it's just that, it's a tool, but information we used to be able to disseminate controlled, now anyone can publish, anyone can post, and there are a lot of people reading a lot of information, and we can't stop that flow, we can't control that flow, but I think we have to just look at our image and make sure that that's what we're doing. With all of those scrutinies, looking at a lot of economic indicators, Chris was looking at the fire service. What have they done? What have they not done? What's happened? How have we gotten here? We know budgets still are shrinking, yet we're asked to do more every day, every last one of us, whether you're private, fire, college, university, private provider, private educator. We know that none of that stops. We're looking at what the public is watching. Overtime cost. The public's finally figuring out what 24/48 actually means. What benefits do you have with things like drop and other things that for the longest time I don't think the public even realized what that was or what it actually meant. Personal use of department equipment, some lawsuits. I mean, just looking, and by no means is this a reflection upon any one department or any one person. It's just some things that we're seeing in social media and things that we're seeing on TV that we have to kind of look at. Chris said one of the things that they're trying to do as they bring their program together was striking 5 phrases from your vocabulary. Just wait until you're blank. And I know none of us have said it, but we've heard it. No one in this room would ever say any of those things. Or, people are going to die. I'm just doing my job. We deserve it. We understand it. And as we add service and as we add value to what we do every day. And then he said there were 5 phrases you wanted to make sure and add to your vocabulary. Is there a way to do this cheaper, faster, safer? The data. What does the data show? What does the raw data? Maybe a few more thank yous. We love what we do. Community deserves. And Rowlett is looking at this when they're starting their community health program of getting the public more involved, more endeared through community health. So they're one of several now. And when I say several, we had identified 16, but I think we're up to almost 30 now that have some form of community health advanced practice in the state. And it's just coming. It's just kind of moving its way through community by community to serve a gap and to take care of their needs. Looked at some cultural change, some things that, prevention over traditional suppression. I think that can also be interpreted as treatment versus just transportation to a hospital. I think for years a lot of us have looked and said, what is there between do you want to go to the hospital, and if not, press hard 3 copies. And I think for years we've had to we've just done that. But now trying to make sure that we stay viable in every way, whether it's fire again or private, what can we do? What can we give the public to make sure that we stay there? Innovation. And that's where Chris was actually headed with this lecture, was that in order for all of us to stay viable in whatever arena we're in, we're going to have to remain viable. Posed an interesting question, and that is, what kind of service adds value and true innovation to our community? So as we look at even the definition of advanced practice or advanced community, these are some of the questions we wanted them to look at. Their program is looking to increase access, primary focus for that underserved population. Whether it was Dallas with Chief Norm Seals who presented, there's an underserved population, but there's also some people out there who are not in the poverty level who just don't know. They just don't understand. As we begin to look at that, we want to make sure that we have a more appropriate use of these services, using equipment when it needs to be used, but if it doesn't, let's not. So just a different idea and just a different approach. The triple aim, this was Matt Savasky from MedStar. They've done a ton of work in pioneering integrated mobile health to the point of changing their name from MedStar EMS to MedStar Integrated Health. Matt's presentation was very long. Matt, are you here? Okay. It was very long, but it was very I mean that in a nice way. It was very long, but I will tell you, I came out of there thinking, wow, there's a ton of things that I know a lot of people in that room just hadn't thought about or just hadn't been presented with some ideas on how to make this work and what was going on. When we looked at the Triple Aim initiative, which is all over this country, there were 3 portions of that Triple Aim, and that was, what's the experience of care, what's the health of our population, and what's the cost per capita, and how can we give them safe, effective, patient-centered, efficient, timely, and equitable care. And that is the Triple Aim. When you start to look at whether it's national quality, almost every program out there is just looking at how can we get better overall care and not continue to do the same thing that we've done just because we've always done it that way. So a lot of information from Matt talking about healthy people and healthy communities and environmental deterrents, social behavior, and then how can we reduce the cost of care. And I think that's probably where more advanced communities really going to come in. We're not going to make a lot of money, but we're going to take our resources and use them a little bit better. Dr. Fagan, who is the medical director for McKinney Fire, also Dr. Malone, help me out, she's the medical director at Baylor McKinney, is that correct for the ER? Fantastic presentation, lots of statistics, lots of things about how they made some things work in McKinney, how they meet the healthcare needs. A lot of this is looking to reduce the demand on the 911 system, and I think that's what you'll find a lot of advanced practice, advanced community, integrated health. That's part of the focus, is to reduce the demand on 911 and give us the opportunity to serve the community in a way that we haven't in the past. Their thing was it's right care at the right time because it's the right thing to do. Very, very wonderful. They were looking at this because for a lot of us, if we read this, this is us. Where a patient feels sick, they dial 911, ambulance comes, we take them to the ED evaluates, admits them or stabilizes them, sends the patient home, supposed to follow up, patient doesn't know what to do, they don't follow up, they feel bad again, what do? They dial 911. And the cycle continues. And I know everybody in this room who's a provider can hear the tones go off and you hear an address and you know who it is. You know what's wrong with them before you even go, because you've been there before over and over and over. And I think a lot of this is an attempt to work with these people to find out what can we do to help you to reduce that, because for a long time, hospitals were paid every time you brought patients in. So the incentive was, we pick them up, we take them to the hospital, we pick them up, we take them to the hospital. We know now that, many times if those patients are taken to the hospital with a similar or same diagnosis within a period of time, people aren't getting paid. So what can be done to keep those folks from coming in, and what we can do to, have that great positive image back, or to continue that great positive image rather, and work with those people. This was just their way of doing it. They had fire administration who was completely committed to the program. They had some really extraordinary medics. They had some medics there. You could talk to them and their experiences about integrated mobile health. Dedicated medical control physician who was dedicated just for this program or understood the program. Had some partnerships, and again, I will go back to that's probably going to be one of the things that we have to really work on very hard, is partnering with people that maybe we haven't in the past. This was not done out of an ambulance, and that was one of the things that almost every integrated provider told us and showed us, that they're not using ambulances for this. One department is using Ford Escapes. I'll show you a picture of the Ford Escape and the people who are going to get in them. They're about 6'3", 6'4". It's just fun to watch. That they're going to use squads, so we're not using all that time and effort on these $100,000 ambulances that we all buy. Funding and then efforts. The triple aim, again, and this kept coming up in everyone's presentation, was aligning with the triple aim to improve outcomes per capita and lower health care cost. Everyone has been building inclusion and exclusion data for who should and who shouldn't be in it. A different kind of consent. I think we're used to actual consent. If we do our job well, we get informed consent. But this is a non-emergent basis. So how do we talk to these patients and make sure they understand what we are there to do, and getting releases and sticking really to HIPAA, because this is a non-emergent situation. The categories, which patients you're going to do, one of the dashboard tools that we found out is that there are multiple, there are multiple categories that you could have your community folks. You could have them doing endocrine and cardiac. You could have them doing cardiac and mental health. And that's probably one that everybody looked at. And if everybody in this room, tell me if your experience is different. When you have that mental health patient, we typically have 2 drugs on board and a transport to a hospital. That's all we can do for them. And what do we do with this population that is not only underserved but misunderstood quite often? And we see them and we take them over and over and over, and we end up with the same outcome. And somehow, if we can be a part of that solution, I think that's probably a great thing to do. Collin College had a course that they're doing where they had advanced physical assessment skills, advanced anatomy and physiology and chronic disease. I'll tell you, I had Dr. Malone, we spent some time together afterwards, and we were sitting there talking, and she took me through a really quick A&P lesson on a napkin. You remember that? She took me through this long lesson on this napkin, and I thought, this can't be taught anywhere else but by a physician. It just can't be done at the level that we're looking at, when these physicians are going to start trusting us to make decisions without talking to them or talking to them. We have protocols and guidelines. This is just a little bit different. So whether we're looking at meds and medical term and ISTAT training, they actually draw blood in the field and make it mean something. And I think drawing that blood in the field and being able to do an analysis and then understand that analysis in the field is pretty good. Again, challenges, funding, mental health patients, again, those chronic patients on a transplant list, meeting the needs of that community, important. Is it sustainable? Well, they've had 2 years and going, and they're looking before 9/11 and after 9/11, when they did this, and then before and afterwards for ED admissions patients taken to the emergency room, as well as those admitted before and afterwards. So everybody that was there shared their data, and everyone had success stories. They had some failures along with it, as we all always know, but for the most part, they had done a really good job. Dallas Fire was looking at their mobile integrated health program as well. Dallas has done a lot of work over the last few years. My hat's off to Chief Seals and Dr. Isaacs, their medical director, presented a ton of information there, and some of it I won't share with you because it was kind of theirs, but they're looking at trying to accomplish the same thing, looking at integration, updating the program as they find something works. They're making changes, updating it, and going. Those are the guys that are fitting in those little Ford Escapes. Their first client contact was in March 19th of 2014. The first enrollment was almost a week later, and now they have the 6 of those guys in 4 vehicles that have Dallas Fire and those little Ford Escapes actually in the neighborhood. And they were telling us a lot of tremendous stories about patients who were actually waiting for them to come. You know, I'm waiting for Bob to show up. I'm waiting for Jane to show up because, you know, today they're going to take care of me and I'm not going to have to go back to the hospital because I didn't know what to do. These firemen are great. We love them. They're absolutely wonderful. So I think as we begin to examine, I think it's, again, just going to be a great opportunity for us. They had 2 different phases, focus on their high-frequency patients and how they're going to navigate those and bridge some gaps. They looked at healthcare, education, diet, client, everything that goes with them, referrals. They actually are taking some referrals from some physicians. It may not have been Dallas, it might have been Plano, that was taking referrals from physicians. If a physician called and had their nurse navigator say, you know what, we're concerned about Miss Jones. She called in. Can you go out and take care of her? Can you go out and take a look at her, assess us, and call us back. Let us know what you see. So it's trying to monitor these patients that way rather than having to go to their primary care physician constantly. The second phase here was a lot of in-home care and a lot of psychosocial care, as we mentioned earlier. That's different for us. The medical care, I think we're okay with, but that psychosocial and social economic care is the one that's going to be a little bit different for us. Medical self-sufficiency, a lot of these patients now are doing much better. They're not calling. There was one case that Chief Seals illustrated to us that they had called 59 times in a calendar year. This patient, same patient, over and over and over. Now, we all know some of those patients, and I thought that was a little exorbitant until showed it to us. But ever since this patient's gotten in the program during the next calendar year, which was 2014, they're down to 5. So just that contact, helping them take care as the baby boomers age and get older, they're going to need a little bit more health care. Phase 2 is their post-discharge optimization program. They have contracts with the major hospitals in their area and referring a lot of those high-risk patients to DFR immediately, referring them and looking at discharge instructions and are you following them. And in several cases, truly found, I don't know if you've ever done this, but you go to talk to a patient and tell them what they need to do, and they say, okay, that's what I'm going to do. And you call again, you go, Miss Smith, did you do this? Well, no. Did you do it? Well, no. Okay, next time you need to do blah, 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 blah. Here we go. We're going to write it down for you. Okay, and you come back again and again. And truly, one of the things that they found out is that there was a population out there that can't read. They have made it through their life. They look like they can, they act like they can, but they can't read. And for those patients, sometimes for us, it might take a little bit more from us to try to get those people ready. We talked, Joshua Klaus from Plano Fire, looking at their program, which was rather lengthy and involved. Again, what are we going to tell you? It might change your life forever, that there really is a hand and it's not just you, but a lot of the information that we're looking at in community health is kind of like that. Plano's readmission prevention program for their community health personnel is CHF, COPD, pneumonia, geriatric fractures, asthma, and diabetes. If you guys wonder why is Jody reading these slides, because I know there are people that are watching on the internet that can't read them, so not that you can't. Again, a lot of referrals on 90-day post-discharge and home safety and routine visits and patient education, again, to keep these patients out of 911 and to keep these patients moving forward. Their program worked. As I mentioned earlier, they had a nurse navigator, patient sent referral to Plano, got all the authorization, got the health records, got a handoff, got them scheduled, got them seen, got a case presented to a doctor. And a lot of this is done electronically. I think everybody in here I see with a laptop, an iPad, an iPhone, and something. So the ability to FaceTime, the ability to look at Skype, can bring that medical director right there to you in seconds without anyone having to use a lot of effort to make this program work. They had a pretty interesting protocol there, 3 different colors, green, yellow, red. If you're green, your symptoms are under control, or caution, you need to contact your community paramedic, or if it's even worse than that, dial 911. So I thought having the algorithm was pretty good, which gave people some direct thoughts and direct comments that they can actually use. Dr. Malone, I'm going to bypass that video.
Please do.
Okay. Dr. Malone, you want to take 10 minutes to come up and explain this?
Of course.
Okay. This was her presentation, so she's here. So if you can do it from the microphone.
Are you going to continue to?
I'm going to give it to you.
Oh, no.
Now she has to use electronics.
Oh.
You want me to just yell ding?
Could I just point to you? Oh, my goodness. Well, thank you very much, Mr. Chairman, for allowing me actually to talk about this. My portion of interest in this is the core clinical content that needs to be taught in order for these programs to actually work. I feel like I need to turn around and talk to you guys. I hate having my back to you. So we developed some core, oh, you're so kind.
A little louder.
Is that better? Thank you.
Go ahead and give me that voice I've heard before.
Do you know, like giraffes, it's very interesting about a giraffe. Did you know when they're born, their necks are not 9 feet long, right? They wouldn't fit through the birth canal. So we don't all get born in our full size. But unfortunately, this is as far as I vertically developed. So thank you, Mr. Schmiederman. Thank you. All right, so let's talk about this. There's some core medical knowledge for this. You keep hearing the same things over and over for a very good reason, because the core medical knowledge that creates the problems are in a way simplistic, but in a way extremely complex. And it's our job to make the complex understandable to these very intelligent individuals who can be taught. So we want to determine what is the core knowledge. We want to find out how do we provide a clinical experience so that the core knowledge is really maintained and understood. And then we want to have everyone know that every system may be slightly different. Their needs may be different, and so a needs assessment locally is going to be done. Jody, can I skip a lot of this?
Skip whatever you like.
Okay, good, but if you're online, not important, not important. So here's the core. I'm going to put all these up here. The core is actually cardiology, nephrology, pulmonology, endocrinology, and neuropsychiatric and behavioral health. Now, those are the core fundamental problems. Most of your patients only have one of those, right? Everybody in the audience? Yeah. Well, even under 60, right? If you look at the data from CMS, the behavioral health issue is responsible for 28% of all the readmissions and 25% of the total CMS care costs. So that's a huge percentage. So we're not just talking about geriatric patients, we're talking about chronic medical condition patients. So we developed a curriculum that puts together that core didactic material that presents actually not only medical communications but therapeutic communications. And I think Dr. Ratcliffe could even speak to this a little bit. When you get a phone call from a paramedic within your system, how much of a difference does it make to you when that individual's using the language that you understand? Does it change your opinion or your confidence in making a decision? So that's everything. And then we've got to put them into clinical sites where we can really know for certain, we can tell if they have gotten the picture, if they've gotten the information, if they recognize the zebra or the giraffe or the standard issue. Now, the first course that we did was 400 plus hours. I think it was 112 or 110, something like that. But you can't really do that for every system. So now what we've done is we have narrowed this curriculum down to 208 hours. 72 hours of that is pure clinical, so that we can have them out into those areas to see what they need to know. What we're going to do is teach these at the medical student level. This is information that we learned as paramedics, but not at the depth that they need to know it to do this in-home care, continuing care, keep them out of the hospital, and to be able to tell if you have diabetes and CHF and asthma, if you have all of these things together and you have a problem today, I need to be able to sort out what's the issue that I need to take care of. Can I take care of something today to keep you out of the hospital? What do I expect the outcome to be? I think these are the most important points that I want to tell you. I expect that the advanced practice paramedic, why do I want to call it that? It is mobile integrated healthcare. First of all, let's establish that. We're doing healthcare in an innovative way. That's why CMS, IHI, that's why they're interested in what we do, because we're going to get healthcare to people who aren't getting it. They're clearly not getting it, because they continue to come back over and over. But we want that advanced practice paramedic to be able to evaluate the patient, formulate a definitive diagnosis, contact the physician, and actually work to keep the patient out of the hospital. They're going to have increased job satisfaction because guess why? We are just not picking up Mary and taking her back again. It's much more satisfying to change the outcome. The fire department cares about us because they're not running fire equipment to non-911 emergencies. We don't get them out of bed at 4 in the morning off the fire crew side. And since we're not using those ambulances for non-911 calls, we have an ambulance when somebody really does have a big trauma or a heart attack. What does the emergency department get out of this? They get available beds for true emergencies. Okay, I'm going to turn around for those of you that are watching me. I'm sorry about all this, but show of hands, how many of you deliver patients to hospitals and you have your acute STEMI on a stretcher in the hall while you wait for a bed? Nobody. Okay. Oh, good. Thank you very much. All right. So there's the truth right there. Not only that. We walk into emergency departments today and it is utter chaos. It's chaos because the patients have nowhere else to go. And so that's the safety net. So we're going to make the patients in the hospital who need that care, the nurses and doctors who are giving that care, we're going to increase the patient safety by decreasing the chaos. I expect this to give our patients increased quality of life. I expect to reduce our overall medical cost, and EMS is beginning to treat the cause and not the symptom. Thank you.
Thank you very much, Dr. Malone. I always find that bar every time, with a knee. As you can tell, there were a lot of people, a lot of topics, a lot of great information there. Also, Jack Ayers was there, and if you've been in EMS any time at all, especially in Texas, you hear the name Jack Ayers. Jack is a attorney, paramedic, who's been working in Texas forever. Jack hasn't changed at all. I hadn't seen Jack in a while, and got to see him at the symposium, and there were the legal side, looking at Can we legally do what we're about to do? Can we legally continue to do what we've done? Can we whatever? And Jack put together about 17 pages worth of laws, Texas Administrative Code, dishes rules, and he went over every last bit of it and said there's certainly no law or rule that says you can't do what you're doing. You can't do what you guys are wanting to do and are already doing. I'm looking back in the back, and I see Melissa's here. I see Jennifer here. Anybody else from NCTTRAC that was involved in that? They did the yeoman's work. They did the load. They pulled this. They put it together. We were in a great venue, which is Uptown in Grand Prairie. It was absolutely wonderful, and I just want to give you a hand. Thank you guys for doing this for us. They didn't do it for us. It just happened to coincide at the right time. Rick, if you're here too, thank you, because for us to pull all of these people down here, which we've been trying to pull some content experts down here like Dr. Malone, but we wanted to get as many as we could. It just wasn't working, but they were able to pull all of these people together. Melissa, when you came in, I only used probably 30 out of the 257 slides that were there, and I didn't make copies of anything because you had the copyright down at the bottom, so just wanted to let you all know we didn't violate any rules. That being said, at our April 10th meeting at Coastal Bend Rack, and Coastal Bend Rack, thank you very, very much for allowing us to come down. It's always nice to go to other racks and to go other places. We had 2 meetings that day. We had our meeting, and then we had the education summit afterwards. And Lori grabbed a marker and went to the board, and we started working. And committee, you have the results of what was on the board that day. Instead of taking notes, Jeff McDonald said when you write it all, he just took his camera out and took a picture, and which is our new way of taking notes, like our students like to do it now, right? They don't want to write. They just want to come take a picture of it or have you hand it to them, which will give us the focus for our next meeting. But looking at what we think is needed for the advanced certificate, looking at the medical legal side, which again, this seminar actually took everything we had on the board. It was kind of interesting. Before we even knew what they were going to do, we found we were kind of on the same track, looking at medical legal, looking at anatomy and physiology, looking at should it be college level. But we said, it doesn't have to be delivered in a college or a university. You can do it anywhere. It just has to be at that level, and then taught by the medical director instead of medical directory. Looking at the chronic conditions, we probably need to continue to work to develop the list and look at those advanced medical conditions, look at the assessment, advanced medical, looking at comprehensive. Then on the back, mental health system, social work, durable medical equipment, therapeutic communications, as we look at advanced pharmacology, true advanced pharmacology with pharmacokinetics and pharmacodynamics, and then safety, because this is, again, a little bit different where we might have one person at this house where we're normally having an ambulance and a police officer or 2 and an engine company, and we've got a lot of folks there. So if something happens, you've got some backup. Where in a lot of these situations, it might just be one. And I don't want anyone to think that we haven't thought about that. Again, kind of changing the paradigm. We've looked at home health nursing, and they've done it. And what can we do for error prevention? How can we make sure that we don't make mistakes in trying to make sure our patients understand that they're not making errors either in what their physician wanted, and then to look at their clinical component. Okay. Committee, having looked at what you've seen here and the notes, did the notes accurately reflect what we did in Coastal Bend that day? For
Yes.
Those of you that were there? Okay, good. With all that being said and all of that out, shall we continue to work, continue to define everything that we've looked at here with input from everybody else? Dr. Malone is representing the Medical Directors Committee on this one to look, and as we just keep looking and digging, we are at nowhere again, we're nowhere close to saying, hi, we're done, this is it. Again, this is information gathering, but a lot of information has been gathered now and put before us to have us take a look at. So, committee, shall we continue, leave it on and move forward? Lori?
We definitely leave it on the agenda and we definitely move it forward, but I think we're at the point in the development process where we've got to network with medical direction.
Great. Any other comments, committee? Justin Boyd, good morning, sir.
Morning, Jody. So last week, unbeknownst to us and what we were getting into, Eddie and I traveled to Cheyenne, Wyoming to the first annual National Rural EMS Conference. And at the National Rural EMS Conference, it was a day-and-a-half conference. We were inundated with about 9-10 presentations on community paramedicine. What's going on in Minnesota, what's going on in Wyoming, what's going on in North and South Dakota. I've got those presentations. I've actually shared them with Wade and what they're doing up there. A lot of the conversation was talking about integration in the critical access hospitals and how the critical access hospitals are using those community paramedics and the system to help benefit them. They talked a lot about flex programs and how the flex programs are tying into this. There was a lady from the Texas Department of Agriculture in the Rural Health Office, Megan Cody, that was listed as going to attend. She was unable to make it. I've emailed her and we've been in a little conversation. I truly don't know what the flex program is and what that brings to the table, but in the rural areas and the frontier areas, when we got to talking about up there, they are moving forward with that, and they have, just like you've explained through your slides, the same type of hurdles and challenges and consistencies. Now, the one thing that they did reiterate is that we have to find the standardization, not only for Texas, but for the entire U.S., because we have to look for a payer source. Right now, if we don't have consistency, we don't have a payer source. Medicare is probably not going to do this if we don't find that standardization. I'll be more than happy to. Wade's got the PowerPoints, and it's not that Wade and I rode down here together.
It's okay.
He was given, he was given them a couple days ago, so I'm sure he hasn't had time. I'll be more than happy to share them with the committee, but it's going through that process too, and looking at what they're doing was eye-opening for us. You might put on there the Texas Department of Agriculture and the Rural Health Office in their role in this as well. Just some thoughts.
No, thank you. Thank you. That is what this is all about. We know that other states have started this, and we're kind of behind the 8 ball on it, but what we do, we kind of want to do it well and do it well thought out and have a good plan and not just throw it out. Joe, do you have any comments? Because you were at the seminar as well, and we've been talking about this back and forth and what's going on nationally.
Excuse me. The seminar obviously was fantastic. I mean, it really brought together, and I think what it really showed is Texas is a true leader on this in so many places where we feel like sometimes we're just beginning, but we've driven this bus for a long time. And I think it behooves us to continue to drive the bus and set the standard for the national, because I think we are in that position to do that. So, I like that this committee is continuing on down this road, because I think it is a worthwhile topic. And I do have to agree that we've got to somehow start getting this molded into a model so that we can start selling it to insurance companies and CMS and the federal partners, so they understand exactly what we're doing, because everyone's a little bit different. Not that it's a problem always, but there has to be a core foundation to the whole program.
Joe,
so I commend you.
In your travels, and I know you've seen this, and I'm glad Justin and Eddie were able to go as well and bring that information back. Have other states talked about this as a card, as a state certification, as a what do we need to look at? Because the standardization is going to be the key for funding. What is it we need to start looking at? Do we say, okay, after X number of hours, you get a CE certificate and your advanced practice? Or do we need to set up a certification when you finish this, here's a card? Or is this something that needs to be looked at through the state? I just so as we go through, I just want to make sure we're going in the right direction.
Sure. I don't know of any state, and Justin, maybe you know, I don't know of any state that has an actual certification community paramedicine or integrated paramedic or whatever the case may be. But by saying that, I still think we need to have some kind of a core education program that something's basically the same. It'll be difficult in Texas to say that there's such a provider when we have this delegated practice, and what may work in some areas may not work in others, where you need more freedom in some areas than you do in the others because of the rural or the frontierness of it. It's going to be a little bit harder. I don't know that I would waste my time, not that it's a waste, but I don't know if I would spend a lot of time on trying to figure out should this be a certification or not. I think we move toward making a foundation. Here's the core value of the program, and let it drive itself and see where everyone else is going with it. I know NITS is looking at it. I know the National Association of State EMS officials are looking at it. I know that there's, Gary Wingate, all those people are looking at that. But I think we'll spend our time better by just setting up our core values and our core program and moving forward from there.
Thank you, Joe. Dustin?
And Jody, I think in those slides, there's a little bit of discussion about what Minnesota's doing, and they don't have a certification. They've just got education requirements. But a lot of those guys just aren't incorporating paramedics. They've broken this down into levels by education for even basics to be going out and doing community health. So they didn't really, from what I remember, granted it's been a week ago, those slides will get to you, and it'll kind of define what some of the other states are doing as far as answering that question, Jody.
Okay, thank you.
Jody, if I could, just to add to your comments about the multiple levels of community health, we have talked about that in work sessions, and we felt that what we could do with the development of this core is that we start at the advanced level, and we set the advanced level at the paramedic level, and then we could work from that down to the other certification levels. So while it seems that, and you hear us talking about advanced practice paramedic and paramedic level, we understand that communities need this type of program at different levels, but we needed a place to start to pull the model together, and we do anticipate that we will get to those other levels. So we don't want to sound exclusive. We really want to make sure that you all understand that we are including all of the certification levels, but we just had to have a place to start.
Absolutely. Dr. Regler? Go ahead, Sam.
Oh, that's all right. I just have a couple things. One, to add to what Joe stated. As far as NASIMSO is concerned, they do have a mobile integrated healthcare committee that works with the rural EMS committee that are working on the development of guidelines at the national level. And as they move forward and as we move forward here, I just had to remind you, don't forget the kids. It's not just an adult issue, and that there are pediatric mobile integrated healthcare programs that are beginning to be developed. One is Indianapolis, Indiana has a targeted issues grant that they're working on to decrease the recidivism of children with asthma. And actually, and I don't know if they presented us at the symposium in Dallas because I wasn't able to make it, but the Dallas and Plano fire departments are working with children's in Dallas on a children's mobile integrated health program as well.
Yes, and in fact, you're absolutely right. It was part of the presentation.
Okay, thank you.
You bet.
I think asthma is huge. Am I next now, Mr. Chairman? I'm sorry. Okay. And Oscar, you've already failed. I told Oscar when we started if I grabbed the microphone to take it back and not let me have it. I think asthma is huge. So we talk about all these processes where if we send somebody out, and Dr. Malone, this is what you were talking about. If we have a process that derails slowly, such as worsening heart failure or asthma recidivism or anything else, if we have somebody who can go out and break that chain and say, you're getting worse, let's refill your inhaler, give you a dose of some steroids, and then you're not going to wind up in the ER at 3 o'clock in the morning. I think we all agree that's our goal. And I'm so happy. You guys know I've jumped up and down at the meetings and said funding, 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 and I sound like Scrooge McDuck or something. But we're going to have to pay for this. Some services are blessed with enough of a budget or, grants or whatever that they can actually do some of these things with what funding they have. But again, I have a lot of agencies right now that are ready to start a program and ready to start interacting in the community, but they're scared to let it out of the box. Because then, council or the community or whoever says, great, this is awesome, guys, do more. Yeah, do more with this. And without any funding, by the way, or extra FTEs or anything else. So I'm scared about a couple of things, and I don't know how we solve this, but my concerns are this. I think if we don't ever actually put some teeth in, I'm sorry, Dr. Malone, if we don't ever actually put some teeth in a credential or something, this may go the way of the critical care paramedic. So who has a critical care paramedic certification in the room? Are they all from there's a few people. Are they all from the same place? You talk to people and they're going to give you their card or their certificate or their diploma or anything else, and they say, well, I'm a critical care paramedic. And I say, okay, great, what does that mean? Can anybody give me the standard definition of critical care paramedic? And I don't think we can. That's what I'm scared about. And I think when we get to the point where we're going to start looking at funding, I think whatever the governing or crediting body, whether it's CMS or JACO or whoever, NHTSA or whoever that comes in to look at a program that's a community paramedicine program and says, yes, we're going to give you a piece of this funding or not, they may not look individually at certifications. They may look at the merits of the overall program. They may look at benchmarking and see, so far during your one-year pilot, have you been effective in asthma reduction in children or some of these benchmarks. I don't know if it's going to matter whether we have EMTs or paramedics. I know we had that discussion where we set the bar. But I think if we're going to lead the way in the state, I don't want to shove this down anybody's throat, but I'm scared if we don't set a benchmark that this is going to go the way of the critical care paramedic, and we won't ever get there. I don't know.
May I approach the bench?
Yes, ma'am.
Dr. Ratcliffe, I totally agree with you, and to me, that's where we are. And I believe that the initial issue here is centered between the Education Committee and the Medical Directors Committee, because remember, the state of Texas is a medical direction state. What we decide that would be available doesn't mean every medical director in the state has to enact it. So since we're not where Minnesota is, we didn't develop the training and then get the certification and then get the billing arm. Now that's what Minnesota did. They just took all of it right straight through their own legislature. But if we can agree that this, as we look through, what does this core really look like? I want to go back to what I said. So you think about cardiology, pulmonology. That's not exclusive to age, right? We're not just talking about the recidivism of patients who are adults. We're talking about children with diabetes, with asthma, there's plenty of kids with heart disease. So this is not exclusive to adults, and I think it's really critical. That's why I'm hoping, not to say what I'm going to say later, but I'm hoping that the Medical Directors Committee, together with the Education Committee, can form a real task force and look at this, because it's being done, it's happening, and I think you guys, as the Education Committee, need to be partly driving this. I think it's a related thing that we need to move forward with and establish it, like you said, before it disappears in front of us or it means nothing.
Wade?
I may get flogged, I don't know, but I want to follow up on what Dr. Radcliffe had to say. As far as the community or the critical care paramedic, I noticed here on our notes that we have that the anatomy and physiology should be taught at the college level. If we're going to, in my mind, give this any teeth and any validity, it needs to be associated with the college or university. I think part of the critical care issue was, for example, you could go through the University of Baltimore and get that, and that may or may not have any teeth, but then all of a sudden you could go just about anywhere and get it, and it diluted it. Also, I'm concerned that we don't want, for lack of a better way of putting it, we just came out of I got my paramedic at Bob's Grill and Hair Care Center on Thursday nights. We got away from that, and that's a very good thing, and so we want to be careful So my recommendation would be that we continue to keep this tied to a college or university to give it clout, validity, however you want to phrase it.
Thank you.
Jody?
Yes. Jeff?
The National Association of State EMS Officials have put together a task force and have put together a document that's being reviewed by NHTSA right now called Special Credentialing. And it's a process on how you do it. I actually had the honor to chair that committee. So I can share that with you because it is a public document, but it actually goes through a process of, there's so many different types of education opportunities out there, and what this process says, should this be a certification at a state level or recognized at a national level, or not, and here's a process how it should be reviewed. So I will get that to you when you get it out to your committee.
Okay. You know, and that's, again, when we started this process and we said, 3 to 5 years, I think we're pretty much right on target there, because there's so many tentacles and so many arms to this that we need from medical directors and EMS committee. We're probably getting closer to that point now where we probably need to have some meetings with EMS committee there, because now we have something to present. Early on, we had nothing to really present, but now we have parts of curriculum and things that we're moving forward with. I'm probably just going to work really hard, either the next meeting or the meeting after, to have a good work group meeting where we invite medical directors and EMS to come to the table and partner with us. Justin?
Just a quick update. Apparently I misspoke. When I got to the back of the room, I was told that Megan Cody no longer works in that office. She resigned sometime in the last maybe few minutes. 24 hours. I'm not real sure, but a lady by the name of Julie, and I can't pronounce the last name.
Spell it.
Ketelsen, is now in charge of that department, and we talk about
Ketelsen.
Ketelsen. So just clarification.
Kellison. Okay.
I guess my trip to the back, I got.
Those trips to the back can be
Right,
informative.
and also what I was told is no EMS people have applied for the Flex program this current year, so the state didn't reapply for it. So if any of the EMS programs wanted to be eligible for that, the state would have to reapply. Now, what that means, I'm just reading literally as I'm walking back and forth. So I'll share what I've got, and that may be a contact that you can reach out to and visit with. So
You want to get it to us, or Wade, do you want to get it to us?
I'll get it to Wade, and however
Which
you want
way?
to do it.
Okay, perfect, thank you. Any other public comment? Any other committee comment on item 1? On page 6 of the integrated mobile health, Melissa, you might shoot me for this one, but I'm about to read what you put at the bottom. Okay? You all right with that? Okay. You say that now. Anyone interested in developing a mobile integrated health and community paramedicine program may feel free to contact Melissa Christian at mchristian@nitrac.org. So, there she goes. So, if you need some information, come on up here.
Thanks. I just want to take this. Jody, thank you. Can you guys hear me? Jody, thank you for all your support. So I'll take this opportunity to mention that I want, as part of the RAC system, I wanted to open up a work group for those people who are interested in.
When you turned away, say that again. So
I want to open up a work group.
Okay.
And open it up for anybody interested in this initiative, and just so that everybody can come together and share best practices. So if you're interested, just email me. Thanks.
And your email is?
mkristen@nitrac.org.
CHRIS?
TON.
TON. Okay. Great. Any others? Okay, we'll keep moving forward. A lot of information today. Thank you very much. Item 2, development stroke-specific continuing education objectives for EMS personnel, certification, recertification. HT, you in the room? Sir. There. You know, if I put these on, it works great at distance. There you are. I just can't read with them on. A couple of days ago, HT provided us with about 9 abstracts from the American Heart Association looking at stroke, International Stroke Conference, poster presentation on recognition by stroke by EMS associated with improved emergency department quality of care, clinical characteristics of pseudo-negative cases in pre-hospital triage for stroke, hospital and EMS collaboration to improve field stroke recognition. Is there a ceiling effect for EMS stroke diagnostic accuracy? Overview of stroke, overview of key factors in improving access to acute stroke care. That was a repeat. Stroke education to enhance EMS field triage. And the last one, improvement in door-to thrombolytic time in a rural community hospital. If I remember correctly, and we should go back and refresh everyone's mind, including my own, a couple of meetings ago, HT came and asked if we would give them some assistance from the Education Committee in looking at stroke care. Initially, there was a request to add content-specific stroke education to the additional hours that are already on the books. Committee met and talked, and at that time didn't feel like designating that time frame would probably be in the best interest, but certainly wanted to take a look at the information there and find out what was being taught in programs. We also wanted to make sure that from the stroke committee that we were able to look and say, okay, what do you have? What do you want us to look at? So I'm going to take it, this is what you want us to look at?
This is kind of an overview of these abstracts came from the stroke convention in Nashville in February. It's not just focusing on just CE. It's the fact that things are changing, and they're seeing more and more need for EMS to be recognizing stroke. First of all, to respond to stroke, okay? Folks need to call us. We need to know what we're doing. One of the studies brought out that stroke diagnosis was missed an alarming % of the time, okay, by groups. We need to have a transport destination developed, okay, whatever that would be. It's not arbitrary, and we got to take them across the state to do things. It's wherever you're at with what you have available. What do you need to do? So we need to look at that. What do we do for that patient? What we got? If we're going to, from my place, take them to a stroke center that can, interventional stroke center, we're looking at 2 hours. If we don't have a helicopter, that's cool. We're going to be with them for 2 hours. What are we going to do? We kind of, years ago, I think, and we're talking, it's just a stroke. They're going to just be, you put them in the truck, take them, my first cardiology, they tell me, don't worry about AFib, it's not important, won't kill you. It's just there. It's okay, and that's changed. And so as stroke things are changing, we just simply need to look at how can we keep, I don't look melodramatic, but this is
as long as there's not a pistol in there, we're all right.
You want me to come to your house with this empty bag, or you want me to come to your house with some knowledge and some skill and some training? That's what we're asking you to help us do. Fill the bag, okay? However we need to do it, we're okay with that. But don't let this go when the stroke's fixing to take off, and we're fixing to have the ability to do things that we have never done before. But we've got to get the education thing going. We've got to get caught up with it. It doesn't have to be, I'm not talking cards, I'm not talking mandatory things, taking anything away from physicians on the local level. Your physicians on the local level need to be brought to the same speed as the rest of us. Hey, we are a long ways from anything. We need to make a plan that works, and we need to see what's available and see what our guys can do. And so in this education process, this helps bring us all together, I think.
Committee, questions for HT?
I'd like to make a comment. One of the things that we need to understand is that paramedic level is just the first thing that happens in your education. After that is involvement with the departments. I actually work for the El Paso Fire Department, and the involvement in the community with the RAC systems is what drives transport and procedures, and of course, like in your committee for stroke, bypassing. So it's a local process, but the involvement of those programs are what makes it important and what makes it valid. Okay, so as far as the CEs and continuing education, I think that's a parameter that can be addressed through the curriculum. But if you're looking at affecting patient care, is the actual involvement of those paramedics, those programs in the community to be on the forefront of what's happening. So I'll give you an example of what we did. We actually attend the stroke committees of all the hospitals, okay? And in there's information that's driven. We actually take our training officer to go to those meetings. And from that's what drives some of our education on the local level to actually drive good patient care. So I don't want to discredit having CEs specific for stroke, but I think there's a better value on the local level to actually make an impact at patient care, the appropriate patient going to the appropriate facility at the appropriate time. So that's my take on this. I value the care that all the departments do throughout the city, throughout the state of Texas. But I think we need to be more involved at the local levels, and that's what I task a lot of people to get involved with their local levels.
And I totally agree, and I think you're blessed to be where you're at. But I have to say this, there's a lot of us out there don't have that, okay? And we're not going to get it unless someone helps in and steps in and helps us make a start. In the education part is not a determining factor. The CEs are not a determining factor. You will do this. It's to make folks aware, hey, this exists, this is changing, this is new. You know, what you were told about AFib or stroke years ago, it ain't the same. There's a change. And that's all that I think we want to do, is to make a beginning. Certainly not to take away from the local level, because I can assure you, your level and my level where we're at, two different worlds, two different things are going to happen. But you're right, we need to look at it. And it needs to be better handled, I think, by the medical directors in their areas, because they know what they can do and can't do. They know their people. Well, you know, I've got paramedics, but I'm not sure. What does that critical care thing mean? I don't. You know, it really. I mean, that's life. It's true. And so we just want to simply begin statewide, including everybody, because I think the system that you're in. I mean, I got to tell you, I'm envious, honestly. Because we don't have that, and I don't know that we can get to that point. In some of the areas we're at, we can't get doctors to come to the RAC meetings because they don't have time. And they just don't have time. I mean, we've actually moved our meeting locations and times to accommodate a physician that has yet to show up. It's 2 years now, hasn't been there yet, doesn't know where we're at. We're in his hospital. We're down the hall from him. That's the frustration I think a lot of us are feeling. If we could just get some guidance and some group participation statewide, all of us have to be exposed to that. And I think that's what we're out to do. I don't think we don't want to take anything away from our medical directors, require additional CEs, make it difficult. We don't want that. We just want to, all of us, be able to hopefully someday get to a system that works like yours, because that's the way it should be.
Have you tried feeding the doctors? I know that's the way we get them to come. We feed them and they show up. Just a thought, but yeah.
We have a lady who cooks breakfast for us at our meeting at home and brings it.
Wow. Yeah. HT, so let me ask committee, did everyone get the email with these abstracts in them? Okay. You know, that abstract is meant to be that, you know, short descriptor with some short answers. Yeah. Would it be appropriate, guys, for us, since we just got them the day before yesterday, for us to take these, read over them, look? I've already read these, but if we take these and make sure that CE is covering what's in these abstracts, with that, I think that would give you the start that you need to get going, and then we can treat this initially, I guess, as a CE, I don't want to say issue, but make sure you've got CE, and then backdoor this into curriculum to say, okay, we just need to make sure that hopefully this is being covered, and if not, hopefully ask, and that's all we can really do is ask to say, here's the synopsis of all the abstract, this is what's being missed, because we're basically talking assessment, diagnosis, treatment, and transport, if I read all these correctly, and then give some recommendations back to you. That's really what you're asking, right?
Yes.
Okay.
This is an overview. This is
Okay.
just kind of the direction we're beginning to go, because like I said, things are changing a little bit, and they're going to hopefully improve, and our systems will improve, but I think this is a start to get us together and saying, hey, there's some changes, guys, look at this.
HD, thank you for getting this to us, because this, it was kind of that big subject that we're going, okay, not sure where we're going to start with stroke, but if this is what you want us to do, and certainly what Oscar said, and that's one of the things that has happened in a couple of meetings. We've gotten a lot of information from a lot of people on a lot of things saying, this is what I'm doing, try it, this is what I'm doing, and I can't tell you how much I think that fulfilled roles and needs in sharing. So we'll take this to the next meeting between now and then, work through this process, work it in work group, work it up, and probably have I don't want to say position letter, but at least an opinion back, what's missing and what we can try to do to help.
Thank you.
You betcha.
I appreciate it.
Mr. Chairman, can I
Yes.
issue a 30-second
Sure.
challenge?
Go. Ooh, a challenge.
So,
I like
challenge,
it.
yeah, and this
I like
is
it.
on behalf of the issue to our stroke committee. So part of these articles repeat over and over and over and over again that are pre-hospital stroke detection tools. So, Cincinnati and LA, things like that we've used forever and ever and ever are terrible. It's better than what we had, which was nothing. Okay, I don't want to discredit the authors of those studies, but so the challenge is, and we're starting to do this in our area, I have a great stroke-trained neurologist. I know not everybody has that. It's a blessing. And she has energized us to say, hey, what are we going to do about the pre-hospital area? So we're actually piloting, a little bit of research ourselves in Bell County on pre-hospital stroke screening tools. But we need to be doing this, because the number one thing that we have to do that all these articles say is detection, 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 and then the fifth D is disposition. We have to know where to take those patients, just like you said. Absolutely. Has to be the right place. So we got to do our part. We got to work on figuring out how to do the detection piece.
In our meeting yesterday, we didn't have a quorum. We were to discuss the LAMS approach to that. Apparently that's gaining quite a bit of recognition and support. We didn't get to do that, so hopefully next time we will. But yes, I totally agree. There's a lot of changes coming, and you're right. This is what we've been using. If that's going to change, let's get us on the same page and let's do this together. It doesn't matter if I'm in El Paso. I know what those guys are going to do to take care of me, or if I'm wherever, and that's the way it should be. So, thank you.
Any public comment on item 2, 3, 2? Morning, Linda.
Hi. Linda Dickerson, GTAC public member. You know how I feel on continuing it for stroke. I'm a baby boomer. I'm your demographic right here. And it's important that you're able to detect it. And it's great. The racks, you know how I love the racks. Each and every one of them. Without them, our state would be lacking beyond belief. And they're not given the respect in our state that they need to be. But I'm from the old school. If it's not measurable, it's not going to be done. If I have to take 12 continuing hours and I can take them in whatever I want, and I'm 25 years old, unless I have a mother who's old like me, I'm probably not going to take stroke. There's a lot of other fun things to take. You're going to have to require stroke at some point in time just to have people to do it. And we've got conscientious people. But do think, because I know the rats can only do so much, because sometimes they're not given the respect You know, and they can say, I want my people to do this, but unless a medical director says you will do this, it's not going to be done. So, remember the old people, that's me. We've got to have somebody that can say that I'm having a stroke and that I'm just not demented. Thank you.
Thank you, Linda. Eddie?
You know, I just want to, everybody's talking about more and more and more on the paramedic. Yesterday in Air Medical, we talked about more and more equipment on helicopters and everything. I think that's all good and well. I think the training is excellent. But don't forget your rural and frontier areas where that stroke, if you're in Dallas, Texas, and you're having a stroke, guess what? You're going to be at a hospital in about 5 minutes. Great. If you detect it in 3 minutes, that's even better. But if you're out in West Texas and it's an hour and a half or 2 hours, so you might keep that in your study and how this is all going to play out at the end of the day, because those rural and frontier areas are probably where your time frames are going to get stretched way out. We can do all the studies we want to in Dallas, Fort Worth, and Houston, in the big cities. Excellent places to do those case studies, but until you put it in real world, rural Texas, I don't know that it has a whole lot of meaning to it.
You know what, Eddie, and I agree with you 100%. In fact, I think this would probably have the biggest effect when we finished on helping support the rural area to find out what's available, what we can do, because you're right, the cities can tailor this a lot differently, so agreed. Chief Kaya?
Well, Dudley's not here, so apparently I'm playing Dudley for,
okay.
For this deal.
I would not have said that on the
tape. Just to let you know, the EMS committee has held a couple of stakeholder meetings to go over the revisions, and the idea of allotting more or specifying like for stroke time did come up at the March 5th meeting, and in general the stakeholders were opposed to making that change. Okay. So just for the EMS committee, education committee to know.
Thank you. GK, good morning.
Good morning. GK Sprinkle, and I'm speaking for myself as an EMS basic. Please don't do more carve-outs unless you're going to take away some of these things, because it's very hard to figure out how you're going to put all those various things together. I'm perfectly happy to go to stroke stuff, but if I have to have a calculator and a degree in mathematics to figure out how to get all my continuing ed and keep my national registry and keep my Texas, it's really hard to do that.
Okay. Thank you. Any other public comment on item 3 or 2? God, I keep wanting to move to 3, 4, 5. I know.
You just don't want to talk to me.
I always want to talk to you. Good morning, Brian.
Good morning, sir. Brian Norris from San Antonio Firefighters. One of the trends that it looks like is going on around the country and also here, hopefully in the state of Texas, is reduction and more focus on appropriate continuing education for our paramedics to keep them competent. I would be very hesitant to carve out a specific area such as stroke when we're looking at trying to focus on need in a particular system. Same reason we have delegated practice, same reason you see one EMS system in Texas, you've seen one EMS system in Texas, that's it. And so to carve out stroke when that may not be the particular need of that local area could be, it probably wouldn't be beneficial, because then we're not focusing on the other things that we would need to focus on in another area. So thanks.
Thanks, Brian. Any other public comment on item 2? 2. Chief Cunningham, is that you? I don't have my glasses on, but is that you? Wow, okay.
Jody,
good morning.
This day you probably thought you would never hear from me, but I'm going to go against what they say. Stroke is such a leading cause of disabilities. Used to, we looked at the older generation. These days in the Dallas area, we're seeing them down into the 16, 17, 18-year-old range, and it's something we've been focusing on with the stroke committee at the NTRAC. I have to disagree. Stroke is a huge, huge issue in the United States, and specifically Texas. I can't tell you exactly what it is anymore in range-wise and the number of deaths and stuff, but think about the monies and everything else involved in it. Things are changing, and again, this is where you and I have had disagreements in the past, but if we don't put those recommendations in there, then it's not going to take place. And I think it is a huge enough issue, and we know more and more about it today, that we do have to carve out some training time for it. We have anaphylaxis. It's a 1-hour required CE for the state. Yes, it's an issue. Which one do we see more of? Anaphylactic reactions, or do we see more stroke patients? Again, I think we used to just really pass it off that this is something that's going to happen in your 50s, your 60s, your 70s. Grandma and grandpa, there's nothing we can do about it. Now there are things we can do about it. There's different treatments out there, and I think it is really even more important for the rural areas to understand what those treatments are and what we can do to get them to the primary or the comprehensive stroke facility. So I'm going to go against the grain for a change, and I'm going to have to say, put it out there, and if we don't start mandating it, then somebody's going to get 48 hours in bedpan 101 because that's the only CE hours that they need for medical, and they're not going to get it in something that's truly going to make a difference in grandma's life, or actually, your son or your daughter's life. Thanks, Jody.
Thank you very much, Chief. Mr. McDonald?
Okay. I understand stroke is a big deal. For those of you who don't know me, my name is Jeff McDonald. If you do know me, it's dirt. But we have a couple of issues with continuing education that we always have to keep in mind. One is that National Registry already has certain areas that you have to get things. I think if you really want to make a difference in all this, get National Registry and put that on their list. Because Texas has always been open, and I think it needs to stay that way. National Registry is also going to reduce their hours next year, 2 years from now, down to, I think, 50 hours for a paramedic. If we start putting all those numbers together, we're going to end up having more hours in certain categories just because we keep putting these scripted areas in there. So I think that stroke is a big deal. If it's that big a deal, why is someone missing it? I think we really need to have that. I think we need to improve it in initial education. That's really where this needs to start. We need to put education on the front end of it to drive it in the first place. And I think that's been a failure. I've been trying to get our stroke areas to give me what kind of stuff they need for a long time, and they keep telling me to do more of it and to be more specific on different areas of the head that are bleeding. Tell me what that is, and I keep getting general signs and symptoms of a stroke. We really do need to focus on it, but I don't think it needs to be a absolute scripted thing within the state. I think we need to follow the National Registry guidelines. One of the things National Registry has is you have to have an ACLS card in order to be a paramedic to stay with National Registry. Part of ACLS requires stroke care. So if the American Heart Association doesn't put it in there, maybe that's an area we need to talk about. So I think there's other areas that need to drive this. We're putting the horse on the wrong end of the cart here. It needs to be driven through the national areas, not necessarily the state areas.
Thank you very much. 4 minutes and 23 seconds left. Any other public comment? None? Thank you. Committee, this shall remain on. We will go back and do everything that we talked about earlier and move forward. Item 3, review Panhandle RAC advisory request to identify existing EMS educational opportunities available in rural frontier areas to identify gaps and develop strategies to fill any identified gaps. Wade was nice enough to get this to us in February, just before our last meeting. We really didn't have a lot of time to look at it then. Justin, I think this came from you too, along with your letter from the RAC. It was the intention of this committee to try to get to the Panhandle in April. Well, with the summit, with the integrated mobile health, with all the things that were going on, April just did not pan out. It was not an excuse. It was just, there was just no time. When we looked at this back in February, April seemed like a pretty good month. It wasn't. I can tell you that there's a list of discussion points that we've gotten, and Wade got this to me. Does everyone have a copy of the document? Listed Panhandle RAC Education Subcommittee. I know some people have had this. We've gotten some input from some of those people. We will continue, and I really, really appreciate you, Justin, getting us something specific that we're able to look at, and we shall continue to take a look at this. I want to tell you when the whole committee will be there. I can tell you if the whole committee isn't, there'll be five or six of us there. One of the things that we're working to do is to try to at least have an answer, and some of the answers this might be, I don't know, but try to have as many answers to as many of these questions as possible. Justin?
So first, thanks for looking at it, Wade, getting it to him. The amount of frustration that my organization, and don't let it be my organization, the organization that I'm a part of and where I'm at, the amount of frustration that exists with this committee is growing tremendously. We understand priorities. We understand things get in the way. We understand all of that. But I've got a map of where this committee has met since 2010, and I've got every agenda. And it's our responsibility as representatives to represent the entire population. We have parts of our area where the average age of an intermediate is 57. We have paramedic average ages of over 60. We realize that this is not something that's a simple solution. These people just want to visit. They want to be able to be heard. They want to communicate. They want to talk. They need assistance. Okay, part of being on this committee is that you had to travel down here and you have to be a part of the system. We understand that. We have TTAF that's broadcasting this. How many of y'all have been to rural and frontier areas to visit with them? Okay, not since 2010, because we haven't talked. We have the agendas. The frustration is that we know there's not a simple solution. They need help. They want assistance. They want to be able to talk. Let's work together as Texas. Has it happened? Not yet. I appreciate you looking at it. I don't know what else to say, Jody, besides we keep telling them when we go back, hey, they're going to come up and visit. We're going to have people up here wanting to talk. Not yet. Okay.
Thank you. Thank you, Justin. As I said earlier, the intent was to be there in April. Unfortunately, with too many things on the plate, X number of dollars in the pocket to make it. But I promised back in November that within the year we would be there. What we have attempted to do is to put together a very wonderful group of people so that when we come, we're not just coming to listen to you, but we're actually coming with solutions in hand. So I realize patience might be a little bit thin, but I think a lot of us do a lot of traveling that's not necessarily on this committee, time's up, that we do it on our own, but we will. Thank you very much. I'm going to, yeah. Item 4, very, very quickly, results of the 2015 Texas CMS Education Summit in Corpus. We had an educator summit in Corpus. Mr. Jeff McDonald sponsored a ton of it. When he and I were talking, we were going to be happy with 15 people. We would have just said, wow, that's great. That's wonderful. This is the first summit. We ended up with over 80, and several of you in this room were there. Thank you all so much for coming to Corpus. Thank you all so much for being involved. I heard from a lot of people, this is what we've been waiting for. We've been waiting for a summit about education. Joe Smeeder had all of his managers there. Joe was there. We had an presentation there. So thank you all very, very much. Any other public comment on anything else? We're actually out of time. Notice she's coming in to reset the clock, picking it up.
Jody?
Yeah.
2 things.
Okay.
So let's look at, you and I talked before the meeting about when we could have a work session to look at the rules and go up to Amarillo. And I'm looking at July 27th through the 31st, that week there. Since you're all sitting here, I thought I'd just throw that date out there and you can work from there.
That's the final thing, actually.
And then I also wanted to I just had to do a little comment on a trip that I had a couple weeks ago to go up to Moss Lake Volunteer Fire Academy to an EMT class. And I got to tell you, it was up in Gainesville. It was a really neat 2.5 hours. And it was an interesting day. I was in a meeting in Fort Worth, and I got to see MedStar and the high-tech operation, and then drove 83 miles up to Moss Lake Volunteer Fire Department. And Jimmy was the course coordinator and his 11 students, and it was an outstanding class. Held it right up till 10 o'clock. It was after 10, actually. And I said, I'm not here to investigate or anything. I'm just stopping in. But I got to tell you, it'll take 30 seconds, I swear. I saw something there I've never seen in my 40 years in EMS, and they do what they call critical thinking. And they have little whiteboards with magic markers that can erase. And it's a simple, low-tech, great idea. They give a patient assessment. It was a gentleman, a 53-year-old guy cleaning out the rain spouts, was collapsed unconscious on the ground. And then they goes to the class, all 11 students, and say, what's your treatment? What do you expect's wrong with this patient? And they all write it down, and they compare it as a group. Low-tech, great review of what they were doing that night in class. Just so simple, but it was really a neat class. I just wanted to comment and commend them on what they're doing up there.
Thank you very, very much. Committee, take a look at July 27th for Amarillo. As you've heard from Justin.
Yeah. 31st is.
Did you mean? Okay, yeah.
I just gave you that whole week from the 27th to the 31st.
More than likely Friday, 31st. Yeah. Just off the top of my head, I don't see anything.
Why do I have June 26th on my calendar?
I have June 26th too, I think.
We established June 26th
At the
as
last-
at the
at
last
the last
work
meeting.
session. Yeah, we said that date at the work
Yeah.
session.
That's what I'm looking at, Joe. Is there some specific reason? Because we had in our last committee, we had said June 26th, and I heard July from you.
I just gave dates that I was available for you.
Okay.
I can do June 26th.
Okay. That was the one that was discussed with us, right?
So June 26th at Amarillo?
Mhm.
By morning?
I'm trying to get that too. 26, right?
Yeah, 26
June.
is good.
June.
June 26th.
June 26. Christine, June 26.
Amarillo.
In Amarillo.
By morning.
We'll set up the venue.
Okay.
Yeah, because I'll need to get that so we can get it. We will have a very limited agenda that day. We will bring as many folks as we possibly can. Anything else? We're adjourned. Thank you.